All right. Good morning, everybody.
Good morning.
It is 7 o'clock. I think people are still going to be joining in, but I know Dr. Song has much to cover, so I want to go ahead and get him introduced and get the meeting started, and people can join as they come along and enjoy today's meeting. So just for brevity, Dr. Song has been with us now for almost a full 2 years. It's been a pleasure and an honor to work with Dr. Song and to have him as part of this meeting and for him to have grown and led this meeting to what it is today. Dr. Song, as everyone knows, is from Asan Medical Center, where he had a very full career and is one of the GI stent innovators of his day. From those experiences, he has taken his experiences and shared them with us here, and he is about to move on and start to share those experiences with a group in China at Xingzhou University. We wish him the best of luck there, and thank you for your time with us. Without further ado, he's going to present two topics today. One is some tips to help lead the authorship conference. I think those are to help myself as far and those that are participating in this meeting. And then he's also going to talk about his stent technology as it relates to obesity in a presentation titled Minimally Invasive Therapies for Treating the Obesity. So without further ado.
Okay, from now on, I'd like to talk about minimally invasive therapy for treating obesity. As you know, obesity represents a major health issue, with the estimates suggesting that more than 1/3 of the world population are affected. Bariatric surgical procedures such as sleeve gastrectomy, Roux-en-Y gastric bypass, and the laparoscopic gastric band and the laparoscopic gastric sleeve are effective, but less than 1% of obesity patients receive surgery every year because of high cost and adverse event. And laparoscopic Roux-en-Y gastric bypass and laparoscopic sleeve gastroplasty result in 30 to 35% total weight loss. Endoscopic therapies for treating obesity, including an intragastric balloon placement, a duodenal-jejunal bypass sleeve, and endoscopic sleeve gastroplasty, have been extensively studied for fulfilling the growing unmet needs for weight management. This is a movie clip showing the endoscopic.
The endoscopic sleeve gastroplasty is a non-invasive endoscopic procedure designed to reduce gastric volume. This animation provides an overview of the latest technique. A coagulation device, such as the argon plasma coagulator, is used to mark the anterior and posterior walls of the stomach along the greater curve. This creates
Okay, actually, this is from Dr. Hani Sheb. Dr. Hani Sheb is a gastroenterologist in Cairo, Egypt. He is famous and he is one of my mentees. He gave me this slide, 3 slides for me. Here you can see bariatric surgery is the gold standard for treating obesity. But less than 1% of the obesity population go to surgery. Exercise is the least risky, but less than 5% of the obesity population see this effect. So he believed that endoscopic surgeries or endoscopic procedures are not even close to mimicking bariatric surgery. So there is a room for interventional procedures. There is an interesting article regarding the decreasing the ghrelin directed procedures for treating obesity. As you know, the stomach plays an important role in obesity, gut-brain signaling, and gastric motility, and endocrine function. The ghrelin is the hormone to decrease the satiety of food. The left gastric artery embolization for bariatric embolization has been advocated, including 6 studies of 47 patients. But the problem is that the total weight loss is just 8.2%. You know that the total weight loss of bariatric surgery is from 30 to 35%. In addition, ghrelin levels get back to normal after 6 to 9 months. Unpublished human data of the full sense device to decrease the ghrelin-directed hormone has shown 28% total weight loss in 46 days, which is equal to bariatric surgery. However, its data in the literature are scarce. We reported our experience with esophagogastric satiety-inducing device in a fossil model recently in 2019 and 2020. To overcome the pitfalls related with the full sense device, we devised 3 types of devices. 2 are fully covered and 1 is uncovered. And we evaluated their feasibility, safety, and efficacy in a porcine model. Though the design is similar to the full sense device. The stent part, this is a stent part, was 24 millimeters in diameter and 20 millimeters long. And this is a disc part, which is 7 centimeters in diameter. A total of 9 juvenile pigs were used for study and was divided into 2 groups. Group A as for control, Group B received type A device. In case of migration, here you can see migration into the stomach, we removed the device with the use of endoscopy, and we randomly placed either type B or type C device. The follow-up studies included the monitoring the food every day and weight change and the ghrelin hormone level every week, and plain radiography and endoscopy. All animals were sacrificed 12 weeks after start. for gross and microscopic examinations. This slide shows the flow diagram. Here you can see all the stent, type A stent device migrated downward within a week. And then all the type B and all the type C, except one, migrated downward within a week again. So we compared the one device with no migration and with the control group. You can see a difference in percentage weight gain between control group and device group, but the difference was just less than 10%. And here you can see that from the 8th week to the end of the study, the ghrelin level in the ESD peak was lower than the control group. This is a gross specimen. You can see severe tissue hyperplasia in the esophagus through the device, and the disc is contact to the gastric fundus. To overcome the pitfall related with the previous version of device, we designed a new device. The proximal part of the device is not covered because it contains drawstrings, and it has 4 anti-migration clefts and 6 bulbs and disc. Also, this is anti-reflux valve, better than the first 3 designs. 8 peaks were used for studies, and we used 3 peaks for control. And in 5 peaks, we placed the device, and to prevent migration, the ESD was fixed in place by 2 strings, you can see, and tied to the peak snout using an anchoring tools made by 3D modeling. This is a 3D. And 4 of 5 peaks from ESD group and 2 of 3 peaks from control group sacrificed 6 weeks after starting experiment, and the remaining 2 peaks were sacrificed 10 weeks after starting experiment. In the one ESD peak, the ESD was removed 6 weeks after placement and followed up for 4 weeks to check for any rebound effect. These are follow-up lateral plane radiographs obtained just after, 2 weeks after, and 4 weeks after, and 6 weeks after placement. The technical success rate was 100%, but migration occurred in 2 of 5 ESD peaks, 4 and 5 weeks after placement due to disintegration of the strings. Even though the migration rate was 40%, it was much better because the previous ones showed migration within a week, but here you can see 4 and 5 weeks after placement. The ESD group had a significantly lower median percent of total body weight gain from the 1st to the 6th week. The rebound peak showed a high peak after removal of the device. Regarding the ghrelin hormone levels, 2 samples from the 2 peaks with device migration and anchors 2 peaks were not analyzed, another 2 peaks, I'm sorry. Eventually, blood samples from the other 4 peaks were analyzed. You can see the difference between EST group and control group. The ghrelin level was lower in EST group than control group. This slide shows the growth findings after sacrifice in an EST peak. Here you can see prominent disc when the stomach is empty and less prominent when the stomach was filled with fluid. And again, you can see severe tissue hyperplasia at the esophageal part. This is ICC immunohistochemistry findings. Cajal cell is the smooth muscle cell in the GI tract. You can see less in EST peak than those in control peak and rebound peak. This study in a rodent model was done by Chinese team. Also, I gave my opinion, so they put my name on the list of the author. So I taught them how to make the device, particularly Dr. Chao, and then he set up hardware shop in Peking University, PUMC, and then there is technologists who make the device. So they made these 2 devices, which is wonderful. And then these 2 devices for rats, not big animals. So the stent was 4 millimeters in diameter and 15 millimeters long, and the disc was 25 millimeters in diameter. And there are 2 discs, a single disc and double discs. Also, there are radiopaque marks attached to each end of the stent and also at the disc. A total of 32 rats were used for this study and were classified into 4 groups: single disc group, double disc group, esophageal stent group, and sham operate group. Regarding the esophageal stent group, they placed just esophageal stent in the esophagus. After device placement, the ESD was sutured to the esophageal wall. Regarding the follow-up studies, they checked the serum ghrelin level biweekly. And this is a histologic finding, and this is gross finding. The technical success rate was 100%. One animal in the double disc group died 2 weeks after the procedure due to gastric perforation. Here you can see the food intake in group, single disc group and double disc group was significantly lower than those in esophageal stent group and the sham group. And also, here you can see, after the procedure, the loss of weight was significantly less in group, double disc group, than those in the other groups. The fasting serum ghrelin remained unchanged from baseline until the end of the study period in all 4 groups, and was not significantly different among the other 4 groups. This is very important findings. This slide shows the growth and HE staining images 4 weeks after placement in a double disc group rat. You can see double disc group here, and severe tissue hyperplasia again in the lower esophagus and stomach. Interestingly, you can see some part of the double disc in the gastric fundus were covered with gastric mucosa. That's why the migration rate is lower. Also, they sutured the device to the esophageal wall. In conclusion, the device placement under laparoscopic and endoscopic guidance is technically feasible and safe in porcine and rodent models. The device seems to induce suppression of weight gain in juvenile pigs and rats, and device, particularly curved device, needs sutures or fixation because of migration. Although we have a long way to go, further studies are warranted to refine the underlying mechanism of ESD related with gastric motility and endocrine function. I'd like to take this opportunity to thank all of you. Since I joined this department as a visiting professor, I have learned a lot and grown much thanks to your support and kindness. I believe that it is a great fortune that in my career, my path has intersected with all of yours. Thank you again for your great support and kindness and help. Thank you.
Well, thank you, Dr. Song. That was always real interesting to see these stints in action, see them conforming to weight loss. Thank you for your tips in the authorship conference. I think you're absolutely correct. We are being outpaced in publication rates. I think there's multiple factors involved when it comes to publications here in America. That being said, I want to open the floor up for anybody who has questions or would like to add any comments.
Well, I would like to thank Dr. Song for visiting us. It's been a great honor to have you here. You could have gone anywhere in the world and you came here to help us. As you know, we needed help with the research program, and you really helped us to build a strong research program that is just taking off. I think we're gonna do great things, but thanks to your leadership, you just planted a seed here for research, and I think it's gonna grow into a very nice program in the future. So we really appreciate it because you really have made a big difference. I want to ask you a question, Dr. Song. In terms of in our institution, research publications are not mandatory, and I think that's one part of the problem. But what other kind of encouragement do you need to put in place so actually people start publishing more? One of the issues that we have here is, as you realize, there's a lot of red tape, and actually doing research here is very complicated because there's a lot of obstacles to actually do something, but it's possible. So what do you think we can do to encourage people to do more publications?
Okay, that's a good question and a difficult question. Yeah. And as you know, I know the severe red tape in the United States, but fortunately, you have a wonderful flow model. You don't need any more. And also you have a lot of procedures regarding the tips and others. So regarding the clinical publications, you don't have any problem. You have a wonderful student and resident. Regarding the translational research, you don't have any problem because you have a wonderful flow model. And also you will receive a grant from the foundations in the United States. The problem is that you don't have a strict requirement. Probably some universities in the state need that strict requirement, because I have learned a lot from the United States, but they lost the competition. So probably you are the director of interventional radiology. You can start from a small thing. It's impossible to control the professors, but you can control the resident. You can invite the enthusiastic resident. Probably you can have a guideline or requirement for just one SCI index paper to hire as a resident. After that, your research laboratory will be the leader in the United States. And also you can have more enthusiastic resident. That is my comment. Another comment is that you have a wonderful partners, including ASAM Medical Center. And also I am going to do international collaboration with 5 institutes in the world, including US and ASAM Medical Center and Zhengzhou University in China, and one in Costa Rica. They are surgeon, and Japan and Hyogo University. They have their own advantages. Also, it's a kind of collaborate research between surgeons and interventional radiologists, and also gastroenterologists. So you can share your advantage with them. For example, if it is difficult for you to do animal study, please ask me. I will do that in China. There is a cost effectiveness. I will put your name on the list of the authors. Also, we can apply for patent together. For example, I have enjoyed my meeting with Dr. Teon. Also, he is a wonderful inventor. I'm going to continue his idea in China to make a big pie. That is my recommendation. So you have a bright picture. Don't worry about it. And I really have enjoyed my first retirement life here in San Antonio. Thanks to you all.
Well, sorry, you had the COVID and that kind of changed everything, but we did what we could, unfortunately. Yeah. Thank you for coming here. Well, okay. The problem is many institutions in the US make publication for the faculty mandatory, and you have to publish at least 1 paper a year. I know within the medical students, actually, you want to get to a residency, you have to publish papers. So actually, the medical students are actually publishing a lot of papers more than the faculty, which is
sure.
Once you get to be a resident, then you're very busy with your residency, and then publication is not mandatory, so that falls again. So I think the issue is making it mandatory, but that will make us very unpopular among the faculty, but it's something that we can discuss later, yeah.
Yeah, that's right. I agree with you. But to be honest, there are too many excuses. Every doctors are busy in the world.
Exactly.
So, you know that Eugene Che visited me and stayed with me for 1 year as a 30-year medical school student from Cornell University. He finished 27 papers in a year. So you have a wonderful medical school student. So you can have a regulation or requirement for 1 paper for resident. And then it is not your responsibility. It's SIR responsibility to have that kind of a requirement. You need that because the US should lead the world, because you have a lot of advantages. No beyond description, wonderful advantages.
Thank you, Son, for your advice.
Hey, Dr. Song, thank you so much.
Dr. Phillips.
Yes, thanks so much for being here. I really enjoyed working with you. We get a lot of ideas. I have two comments. When I first started in 35 years ago, there was not so much clinical work and it wasn't such a big pressure, and the faculty had 1 or 2 days of research. All faculty had that. And then the clinical work got very intense and the schools were pressed to make money. They had financial issues. And so then it made research more difficult. So I was wondering, how much time do researchers in Korea and China have that are medical faculty? How much time off from clinical work? Do they have a day or two? And then one more question on your gastric stents. You know, all obese people from my research have rapid gastric emptying. It empties from their stomach rapidly, and then that causes their sugars to rise rapidly because of the rapid emptying. What's the effect of the stents on gastric emptying?
Oh, that's a good question. Before I answer the question, thank you very much for your friendship. I really enjoyed my life with you and Lauren. Thank you so much. Please visit me, your friend, to China. And regarding the first question, regarding the time, I am very impressed by your activity. You are busy as the other doctors, but you have lots of complications. No, publications, not complications. So it was difficult for me to make a balance between publication, clinical work, and research. But I used weekend, Saturday and Sunday for research, but it was not possible to continue. So before my retirement, 5 years before my retirement, I focused on research. And then they have some program for research professor, but overall in Korea it's the same. Most of the doctors are busy to write a paper, but about 10% of them, they do research. They don't have any time for research in a week. They do on weekend. So I can say less than 10% of Korean professors, they do research 1 day or 2 days a week. Regarding the second question, gastric emptying, I know that you are interested in diabetes. They need food in the stomach. That's a good question. And I believe that the device can reduce the ghrelin level, but that is not necessarily all the result. Probably that is because of filling of the stomach. So when the stent or device migrated into the stomach, the patient lost the appetite. That was my personal experience. At that time, I did not remove the stent because the stent was not retrievable one. That's why I devised a retrievable stent. But before my devised retrievable stent, after stent migration into the stomach, the stent was there in stomach for 3 years. And then it's a kind of capacity. But that is my personal experience, but I don't know that is the right answer. Thank you for your question.
Thank you. It'd be nice to know the effect on diabetes-related hormones, including CK, GLP-1, and Ghrelin.
Dr. Song, I had a question about the study designs a little bit. And one of the questions is either in the porcine models or in the rat model, was there a way to assess discomfort and pain? And was that taken into consideration as part of the aversion to food?
Yes, good question, but I don't know because the pigs and rat does not make any complaint about that. But anyway, that is a cause of loss of satiety. Probably the stench and disc can irritate the stomach wall, which cause pain, but it caused also in some pigs. That's why they should have pain and causing less satiety. But I don't know the right answer. That's a good question. We have to know about the fact through the further experimental studies.
Thank you for the answer. Yeah, I was just kind of curious what effect it had on it, or if there was even a way to really assess it.
Dr. Song, this is Dr. Suri here. Again, I echo what Dr. LaPera and Dr. Phillips, everybody has said. We really appreciate what you have done for our program. I can literally say it's a total 360-degree turn from where we were, the direction we are going to where we are
Still in a
now.
research meeting.
So
Thank
this is something that was very impressive from starting off from literally no translational research to where we are now. And I totally agree with you. We can hide behind criteria that, that, okay, we do not have protected time, we do not have time to do that, but it all comes from within. If we can either say that this is something that is required by an institution, and that's why I'm required to do it, or I'm doing it, publish or perish, but really needs to come from within. And I think that is something that you really highlighted in your achievements, Dr. Amplas's achievements, Dr. Castaneda's achievements, and that's something we all need to learn from. And thank you for highlighting us and bring us back to track. Thank you.
Thank you very much, Dr. Suri, for your joining us and your support for the past 18 months.
All right. It's that time of morning where I think we need to leave our research meeting. I greatly appreciate your presentation, Dr. Song, and for your time with us, for everything you've done with us. It has been amazing to see this place grow in the time that you've been with us, to see the amount of research. I think the sky's the limits, and look forward to continuing working afar with you in many endeavors. I hope everybody has good mornings and a good clinical day, and I will see you guys back here in a week. Take care. Take care, Dr. Song.
Thank you.